Welcome to this video entitled, What is Ventilator-Associated Pneumonia? How do I diagnose it? How do I treat it? As a way of introduction, ventilator-associated pneumonia, abbreviated as VAP, causes significant morbidity and mortality in the intensive care unit, ICU. Ventilator-associated pneumonia is defined as pneumonia that develops more than 48 hours following endotracheal intubation. It is associated with prolonged hospital stays and significant costs. The estimated incidence of ventilator-associated pneumonia varies widely and depends on how it is measured. In 2012, U.S. hospitals reported ventilator-associated pneumonia rates of 0.9 events per 1,000 ventilator days in medical ICUs and 2 events per 1,000 ventilator days in surgical ICUs. An independent audit by the Centers for Medicare and Medicaid Services, CMS, however, found ventilator-associated pneumonia rates of about 10% within selected populations. Evidence-based understandings of risk factors, accurate diagnosis, and appropriate management are discussed in this chapter. We will now discuss the pathogenesis of ventilator-associated pneumonia. Risk factors for ventilator-associated pneumonia can be divided into 3 categories: host factors, hospital and unit factors, and pathogen-related factors. Let's begin with host factors. Microaspiration of oropharyngeal and gastrointestinal organisms is the predominant route of infection, as shown in box 47.1. Next we will consider hospital and unit factors. Patients become colonized with hospital pathogens, e.g., Staphylococcus aureus, Pseudomonas aeruginosa, and other gram-negative bacilli, abbreviated as GNBs, within 48 hours of admission. Accurate and frequently updated knowledge of local pathogens and their susceptibility profiles is essential to inform empiric antimicrobial treatment strategies. Next we will focus on pathogen-related factors. In addition to hospital-acquired pathogens, patients' baseline flora may also cause ventilator-associated pneumonia, especially within the first few days after admission to the hospital. The number and virulence of the pathogens aspirated contribute to the risk of developing pneumonia. Aerobic gram-negative bacilli, e.g., Pseudomonas aeruginosa, and gram-positive cocci, e.g., Staphylococcus aureus, remain the most common organisms causing ventilator-associated pneumonia, while other bacteria, including anaerobes, fungi, and parasites are rare, unless the patient is immunocompromised. There is increasing appreciation that a significant fraction of ventilator-associated pneumonias may be caused by respiratory viruses. Multidrug-resistant organisms are major concerns for patients with ventilator-associated pneumonia. Prior antibiotic exposure and duration of healthcare exposure factors are independent determinants of risk for acquiring multidrug-resistant organisms, as shown in box 47.2. We will now progress to the diagnosis of ventilator-associated pneumonia. The 2016 IDSA/ATS, Infectious Diseases Society of America and the American Thoracic Society, guidelines recommend suspecting ventilator-associated pneumonia in a patient with new or progressive pulmonary infiltrate plus new onset of at least 2 or 3 of the following factors: fever, purulent sputum, leukocytosis, and decline in oxygenation. However, ventilator-associated pneumonia is a notoriously difficult condition to diagnose. The constellation of fever, purulent sputum, leukocytosis, and a new infiltrate is only 69% sensitive and 75% specific for pneumonia compared with post-mortem pathologic findings. Neither clinical signs nor radiographs alone are reliable diagnostic tools for ventilator-associated pneumonia. The difficulty of diagnosing ventilator-associated pneumonia compels humility and a readiness to revise one's diagnosis depending on each patient's clinical trajectory. Patients that rapidly improve after endotracheal suctioning, pulmonary toilet, diuretics, or recruitment procedures most likely do not have ventilator-associated pneumonia and do not require antibiotics. Next we will discuss screening tests, initial detection. Let's begin with clinical evidence of ventilator-associated pneumonia. Patients with ventilator-associated pneumonia can exhibit a gradual or sudden onset of symptoms and signs that include fever, tachypnea, increased secretions, purulent sputum, hemoptysis, and/or worsening hypoxia. On auscultation, their breath sounds may reveal rhonchi, crackles, or wheezing, or may be diminished at the site of pulmonary consolidation. Their measured ventilatory parameters may show declining compliance in the form of increased inspiratory pressure, decreased tidal volume, or increased respiratory rate, depending on the patient's ventilator mode. Impaired oxygenation is a sine qua non of pneumonia in ventilated patients. It is therefore helpful to assess serial ventilator settings to look for a rise in fraction of inspired oxygen, abbreviated as FiO2, or positive end expiratory pressure, abbreviated as PEEP, to support a diagnosis of ventilator-associated pneumonia. Patients with minimal and stable ventilator settings most likely do not have ventilator-associated pneumonia or have mild pneumonias at best. Positive pulmonary cultures in this population are more likely to represent colonization rather than infection. Box 47.1 Summarizing host-related risk factors for ventilator-associated pneumonia. They include the following. 1. Micro-aspiration of oropharyngeal and gastrointestinal organisms. 2. Presence of an endotracheal tube. 3. Other instrumentations such as central venous lines and intracranial monitors. 4. Surgical procedures, etc. 5. Increasing age. 6. Sedation. 7. Paralysis. 8. Glucocorticoids. 9. Altered gastric pH, by medications, feeding or illness. 10. Comorbidities, such as lung disease, multiple trauma, malnutrition, renal failure, and anemia. 11. Recent antibiotic treatment. 12. Previous hospitalization. And 13. Underlying immune status. Pause the video and carefully scrutinize box 47.2 summarizing risk factors for multidrug-resistant pathogens. The risk factors for multidrug-resistant ventilator-associated pneumonia include the following. 1. Prior IV antibiotic use within 90 days. 2. Septic shock at the time of ventilator-associated pneumonia. 3. ARDS preceding ventilator-associated pneumonia. 4. Equal to or more than 5 days of hospitalization prior to the occurrence of ventilator-associated pneumonia. And 5. Acute renal replacement therapy prior to ventilator-associated pneumonia onset. The risk factors for multidrug-resistant Pseudomonas and other gram-negative bacilli include the following. 1. Treatment in an ICU in which 0.10% of gram-negative isolates are resistant to an agent being considered. And 2. Treatment in an ICU in which local antimicrobial susceptibility rates are not known. The risk factors for methicillin-resistant Staphylococcus aureus include the following. 1. Treatment in a unit in which 0.10% to 20% of Staphylococcus aureus isolates are methicillin resistant. And 2. Treatment in a unit in which the prevalence of methicillin-resistant Staphylococcus aureus is not known. We will now progress to laboratory evidence of ventilator-associated pneumonia. Patients with new-onset ventilator-associated pneumonia may have leukocytosis or, occasionally, leukopenia. If a blood gas analysis is obtained, patients may have hypoxemia or hypercarbia secondary to impaired alveolar gas exchange. Evidence for the role of procalcitonin and C-reactive protein, abbreviated as CRP, in establishing the diagnosis of ventilator-associated pneumonia remains weak. However, serial procalcitonin monitoring may help clinicians to shorten duration of treatment. We will now switch gears to imaging. Chest imaging is an integral component in the diagnosis of ventilator-associated pneumonia. A chest radiograph, abbreviated as CXR, may show either a new or an expanding alveolar infiltrate in one or multiple lobes, air bronchograms, pleural effusion, cavitation, pneumatoceles, or pneumothorax. Portable chest radiographs can both overcall and undercall the presence of pneumonia. If clinical signs for ventilator-associated pneumonia are ambiguous, consider computed tomography, CT, as this can help affirm or refute a diagnosis of ventilator-associated pneumonia, particularly if a contrast study is possible. CT can help reveal the presence of an infiltrate not clearly seen on portable CXR and differentiate among atelectasis, pulmonary edema, and consolidation. CT can also be useful in patients who are failing to respond to antibiotic therapy. CT in these cases may reveal a pyogenic complication such as lung abscess or empyema that may require drainage. We will now discuss respiratory tract sampling. There are several methods to obtain a respiratory sample. These methods vary in accuracy, cost, complexity, and risk for complications. Even though both the US and European guidelines recommend lower respiratory tract sampling, the US guidelines favor non-invasive sampling with semi-quantitative cultures to diagnose ventilator-associated pneumonia, while the European guidelines favor invasive sampling with quantitative cultures. The European guidelines favor invasive methods on the basis of a single French study that found that invasive sampling may decrease antibiotic utilization. The US preference for non-invasive sampling is based on a meta-analysis of randomized controlled trials, including the French study, that show no differences in mortality, length of stay, or antibiotic changes with invasive versus non-invasive sampling. As such, they prefer non-invasive sampling because invasive sampling is more difficult, higher cost, and carries some risks. A. Invasive respiratory sampling. Invasive samples of the lower respiratory tract may be less prone to contamination by upper airway organisms compared with non-invasive methods. Invasive methods include the following. 1. Bronchoscopy, which allows one to inspect the airways for signs of infection and for any other pathology that is possibly contributing to the patient's presentation. It requires a skilled physician and has risks for barotrauma and hypoxemia. Two main types of studies are available: bronchoalveolar lavage, abbreviated as BAL, and protected specimen brush, abbreviated as PSB. 2. Non-bronchoscopic methods, which include bronchial washings and mini-BAL. These methods can be done by nurses and respiratory therapists and can be safely accomplished in patients who cannot tolerate bronchoscopic procedures. In mini-BAL, a catheter is blindly advanced through an endotracheal tube, abbreviated as ETT, until resistance is encountered. BAL is then performed per standard technique similar to bronchoscopic BAL. In addition to the risks known to BAL, this method carries a higher risk of endobronchial perforation, and the BAL sample is less likely to be a deep alveolar one compared with a bronchoscopic sample. B. Non-invasive respiratory sampling. This includes endotracheal aspirates without installation of saline into the lungs. This method has multiple advantages, including low cost and low risk of complications, and can be done by non-physicians with limited training. Even though it is least likely to sample the alveoli, alveolar and airway pathogens are often similar in patients with pneumonia. We will now discuss processing of respiratory samples. All respiratory samples are sent for microscopic analyses and cultures. Next we will discuss microscopic analysis. Microscopic analysis includes cytospin, differential cell count, and gram stain. The presence of intracellular bacteria is rare but highly suggestive of ventilator-associated pneumonia. The absence of a predominance of neutrophils, that is less than 50%, makes ventilator-associated pneumonia unlikely. We will now briefly look at cultures. Respiratory cultures and blood cultures are an integral part of diagnosing ventilator-associated pneumonia, but clinicians need to appreciate their limitations. The sensitivity of pulmonary culture ranges from 48% to 75%, and the positive predictive values range from 60% to 81% relative to histology depending on sampling method. False positives are typically due to contamination of specimens with organisms colonizing the oropharynx or endotracheal tube. False negatives are typically due to prior exposure to antibiotics or failure to sample the exact segment of lung in which the pneumonia lies. Culture thus provides one more piece of data for clinicians to integrate along with everything else they know about their patient in order to make a decision such as the clinical signs, radiographic findings, clinical response to antibiotics, clinical response to non-infectious treatments, e.g., diuretics, competing diagnoses, etc. A. Quantitative cultures. Some laboratories are able to quantify culture yield. Different thresholds have been suggested as diagnostic of ventilator-associated pneumonia, depending on sampling method, e.g., equal to or greater than 10 power 5 colony forming units per milliliter, abbreviated as CFU, per milliliter for endotracheal aspirates, greater than 10 power 4 colony forming units per milliliter for BAL, and greater than 10 power 3 colony forming units per milliliter for PSB. But these thresholds ought to be treated as guides rather than hard and fast cut-offs because pneumonia, like any other infectious condition, exists upon a continuum, and sampling technique, laboratory handling, and prior exposure to antibiotics impact yields. B. Semi-quantitative cultures. Moderate or heavy bacterial growth in a patient with compatible signs is consistent but not diagnostic of ventilator-associated pneumonia. No bacteria or light growth make ventilator-associated pneumonia less likely. See qualitative cultures. Ventilator-associated pneumonia is diagnosed based on a positive culture, but no quantification is provided. This method is considered the most sensitive but least specific method to diagnose ventilator-associated pneumonia. We will now discuss respiratory viruses. There is increasing appreciation that substantial number of nosocomial pneumonias may be caused by respiratory viruses. Consider obtaining a respiratory virus polymerase chain reaction abbreviated as PCR panel, particularly during respiratory virus season. We will now discuss differential diagnosis. All the cardinal signs associated with ventilator-associated pneumonia are nonspecific and can also be seen in entities like acute respiratory distress syndrome, abbreviated as ARDS, aspiration pneumonia, cryptogenic organizing pneumonia, pulmonary embolism, vasculitis, pulmonary hemorrhage, pulmonary contusion, infiltrative tumors, and complications of blood transfusion, e.g., transfusion-related acute lung injury or TRALI, medications, or radiation. Lung biopsy may be necessary to differentiate between some of these conditions and ought to be considered in a patient with a progressive pulmonary syndrome that does not respond to antibiotics. We will now discuss the treatment of ventilator-associated pneumonia. Once the diagnosis of ventilator-associated pneumonia is suspected and respiratory samples and blood cultures have been sent, antibiotics should be started immediately in patients with shock or rapidly progressive hypoxemia, because delays in this population are associated with increased mortality. If the patient is clinically stable, however, consider watchful waiting alone while gathering more data to support or refute a diagnosis of pneumonia. Helpful data can include sequential vital signs and laboratory parameters such as leukocytes and biomarkers, culture results, and the patient's response to non-ventilator-associated pneumonia therapies, such as deep suctioning to relieve mucus plugs, diuresis, and recruitment maneuvers. Multi-drug resistance is defined as acquired non-susceptibility to at least one agent in 3 different antimicrobial classes. Extensive drug resistant, abbreviated as XDR, and pan-drug resistant, abbreviated as PDR, bacteria are defined as bacteria resistant to all but 2 antimicrobial classes, and to all antimicrobial agents, respectively. When patients suffer from extensive drug-resistant or pan-drug resistant, consultation with an infectious disease (ID) specialist is prudent to help select an appropriate antibiotic regimen. We will now discuss empiric therapy. Empiric treatment for ventilator-associated pneumonia should include coverage of Staphylococcus aureus and gram-negative bacilli, especially Pseudomonas aeruginosa, because the majority of ventilator-associated pneumonias are caused by these pathogens. Once there is a decision to treat, the choice and number of antibiotics should depend on host factors, e.g., ARDS, renal replacement therapy, septic shock, recent antibiotic exposures, prior pulmonary and non-pulmonary culture results, comorbidities, specifically renal function, hospital-specific and unit-specific predominant pathogens and their susceptibility patterns, gram stain result if one was available, and other risk factors for acquiring drug-resistant bacteria. See box 47.1. In addition, availability of an antibiotic, its cost, side effect profile, and possible interactions with other medications are important considerations. If ventilator-associated pneumonia is suspected in a patient already on antibiotics, it is generally advisable to change the class of antibiotics in case the patient has acquired a resistant organism. Patients with ventilator-associated pneumonia and no risk factors for multi-drug resistant pathogens, see box 47.2, can be treated with any single agent that is likely to cover more than 90% of Staphylococcus aureus and Pseudomonas aeruginosa in the clinician's institution. Possible options include piperacillin tazobactam, cefepime, levofloxacin, or imipenem. Patients with risk factors for MDRs should receive 2 antibiotics to target gram-negative bacilli, specifically to Pseudomonas aeruginosa, and a third agent to target methicillin-resistant Staphylococcus aureus, abbreviated as MRSA. Combination gram-negative therapy to target multi-drug resistant gram-negative bacilli usually includes a spectrum beta-lactam plus either a fluoroquinolone, aminoglycoside, polymyxin, or aztreonam. Methicillin-resistant Staphylococcus aureus can be treated with either linezolid or vancomycin. We will now discuss important antimicrobial considerations. 1. Aminoglycosides are not recommended as monotherapy given poor lung penetration and high risk for ear and kidney toxicity. 2. If aminoglycosides must be used, then once-daily dosing is preferred for patients with normal renal function. Drug level monitoring: a single peak level at 8 to 12 hours after the first dose followed by a trough level 30 minutes before the next planned dose and repeated at least weekly, is important to minimize nephrotoxicity. 3. If Legionella is suspected, adding a fluoroquinolone is recommended as the second antipseudomonal agent. 4. Fluoroquinolones are generally well tolerated, but they can prolong the QT interval, potentiate risk for Clostridioides difficile, and have been associated with neurotoxicity and tendinitis. 5. Polymyxins are used in highly resistant gram-negative bacilli in consultation with ID. 6. Aerosolized aminoglycosides or polymyxins can be used as adjunctive therapy in patients who are failing to respond to intravenous treatment alone. Correctly administering aerosolized medications, however, is difficult and could require sedating and even paralyzing the patient to facilitate laminar airflow. Some case series report that up to 10% of patients who receive aerosolized medicines develop cardiorespiratory complications. Expert societies recommend caution before using aerosolized antibiotics. 7. Methicillin-sensitive Staphylococcus aureus, abbreviated as MSSA, should be treated with nafcillin, oxacillin, flucloxacillin, or cefazolin. 8. Linezolid and vancomycin are associated with similar clinical outcomes for methicillin-resistant Staphylococcus aureus pneumonia. The choice of agent should therefore be informed by other considerations such as dosing convenience, renal function, blood cell counts, use of selective serotonin reuptake inhibitors, abbreviated as SSRIs, vascular access, and cost. 9. The combination of piperacillin tazobactam and vancomycin should be used with caution due to increased risk of kidney injury. 10. In patients with history of penicillin or cephalosporin allergy, a thorough history for the type of reaction is important. Most patients with penicillin allergies can tolerate cephalosporins. Consultation with allergy for skin testing, simple graded challenge, and consideration for aztreonam may be necessary. 11. In patients with renal insufficiency, most antibiotic doses will need to be adjusted and antibiotic levels measured, especially with aminoglycosides and vancomycin. Imipenem and cefepime have been associated with seizures in patients with underlying seizure disorders. 12. Infusions of beta-lactams have been associated with higher survival rates compared with intermittent dosing in critically ill patients with sepsis. Prolonged infusions may also facilitate treating patients with higher minimum inhibitory concentrations, abbreviated as MICs. We will now discuss de-escalation of antimicrobial therapy. Following 48 to 72 hours of susceptibility pattern-guided empiric intravenous antibiotic therapy, culture results and clinical response should be reviewed. Antibiotic coverage should be continued, narrowed, or discontinued. De-escalation is an important step in the management of ventilator-associated pneumonia in order to minimize potential toxicity from antibiotics, risk of superinfection with other nosocomial pathogens like methicillin-resistant Staphylococcus aureus, or Pseudomonas, development of Clostridioides difficile infection, and promotion of selective pressure for more resistant bacteria. In patients who are improving clinically on antibiotic therapy, antibiotics should be tailored to bacterial susceptibility results. For clinically improving patients with negative cultures at 48 to 72 hours, empiric treatment can be discontinued. For patients who are not improving after 48 to 72 hours of treatment, infection with resistant organisms, pyogenic complications of ventilator-associated pneumonia, comorbidities impacting response to ventilator-associated pneumonia treatments, and alternative diagnoses should all be considered. ACT scan and BAL are recommended. We will now progress to the duration of therapy. Both US and European guidelines recommend 7 days as the default duration of therapy for ventilator-associated pneumonia for all pathogens, including Pseudomonas aeruginosa and Staphylococcus aureus. Longer courses are associated with higher antibiotic toxicity, risk of superinfection, and selection of more resistant pathogens, with no significant added benefit. Serial procalcitonin level monitoring can help clinicians to discontinue antibiotics safely after even less than 7 days of therapy. A drop in the procalcitonin level by equal to or greater than 80% from its peak value or to equal to or less than 0.5 gram per liter suggests it is safe to stop antibiotics in a patient that is clinically improving. Exceptions that warrant longer antibiotic courses include patients with pyogenic complications, persistent bacteremia, metastatic infections, and other complications. Consultation with an ID specialist is recommended. Once a patient is extubated and stable from a cardiopulmonary standpoint, parenteral antibiotics can be converted to oral formulations if an oral equivalent exists. We will now discuss the prevention of ventilator-associated pneumonia. Every effort to minimize the risk of ventilator-associated pneumonia and its associated morbidity and mortality should be undertaken. Strategies to prevent ventilator-associated pneumonia include avoiding intubation when possible, use non-invasive ventilation and/or high-flow nasal cannula instead, minimizing duration of intubation by implementing level of sedation goals and paired daily spontaneous awakening and breathing trials, limiting the use of neuromuscular blocking agents and antacids, and reducing the risk of aspiration by elevating the head of the bed. We will now briefly discuss ventilator-associated event definitions. The Centers for Disease Control and Prevention, CDC, developed ventilator-associated event, abbreviated as VAE, surveillance definitions in 2013. Their intent was to expand the breadth of surveillance, and thus the focus of prevention, beyond pneumonia alone, while including other common and morbid complications in ventilated patients, such as pulmonary edema, ARDS, and atelectasis. Ventilator-associated event definitions were also designed to be more objective than traditional ventilator-associated pneumonia definitions and amenable to automated surveillance using electronic health data. The first ventilator-associated event tier is ventilator-associated condition, abbreviated as VAC, which identifies patients with equal to or longer than 2 days of sustained respiratory deteriorations, measured by increased positive end expiratory pressure and/or FiO2, following at least 2 days of stability. Infection-related ventilator-associated condition, abbreviated as IVAC, is the second tier, where ventilator-associated condition patients develop fever or leukocytosis or leukopenia, and are started on one or more antibiotics that continue for equal to or more than 4 days. And finally, possible ventilator-associated pneumonia, abbreviated as PVAP, is present in patients with infection-related ventilator-associated condition who have microbial evidence of respiratory infection on gram stain or culture. Finally, we will consider a few authors' recommendations. 1. Ventilator-associated pneumonia, abbreviated as VAP, is a difficult diagnosis. Consider ventilator-associated pneumonia in patients with new or progressive pulmonary infiltrates plus new onset of at least 2 of the following factors: fever, purulent sputum, leukocytosis, and decline in oxygenation. 2. A microbial respiratory tract sample and blood cultures are integral aspects of accurate diagnoses and can inform the type and duration of antimicrobial therapy. 3. We recommend non-invasive lower respiratory tract sampling with semi-quantitative cultures to confirm ventilator-associated pneumonia diagnosis. Consider testing for respiratory viruses as well. 4. Immediate treatment is recommended in unstable patients with shock or rapidly progressive respiratory failure following the acquisition of microbial respiratory and blood samples. 5. We recommend watchful waiting in stable patients while letting cultures mature. Carefully monitor the patient's clinical trajectory and be ready to intervene if the patient deteriorates. 6. Empiric treatment for ventilator-associated pneumonia should include coverage for Staphylococcus aureus and Pseudomonas aeruginosa. In patients with risk factors for antibiotic resistance, choose antibiotics that cover the drug-resistant pathogens that are most common in one's own institution. 7. De-escalation of therapy to cover identified pathogens should take place as soon as culture results are available. If cultures are negative at 48 to 72 hours, re-evaluate the diagnosis. If another diagnosis now seems more likely, then stop antibiotics. If ventilator-associated pneumonia still seems like the most likely diagnosis, then consider narrowing antibiotics. 8. Treatment with intravenous antibiotics should not exceed 7 days without thoughtful re-evaluation of the individual patient's trajectory and need for an extended course. Thank you.